The Pima County Medical Society presents Prescription for Health, a program designed to help you help yourself to better health. The opinions expressed on this program are those of the individual physician. Your own doctor may have a different opinion. Ask. Today, we're going to talk about infertility. Your host is Dr. Ronald P. Spark. His guests are Dr. Anthea Dixon, whose specialty is obstetrics and gynecology, and Dr. Louis Schenker, whose specialty is also obstetrics and gynecology. Dr. Spark?
Thomas Jefferson said in a letter to his wife that motherhood was the arch and the keystone of matrimonial harmony. In contrast, infertility is a source of great strife, difficulty, guilt, and frustration to many couples. We're going to talk about infertility and some of the problems that involve with this problem. We have two experts here tonight. First is Lou Schenker. Welcome, Lou.
Thank you. Nice to be here, Ron.
And Anthea Dixon. Welcome, Anthea.
Hello, Ron.
Lou, why can't some couples become pregnant?
I wish we knew all the answers to that question. It's a difficult question. And about half the time, we often, after extensive study, don't know why certain couples can't conceive and why others either conceive without help or with help but will eventually get pregnant. There are really only about 5 factors that can be investigated in terms of ruling in normalcy as to whether or not people have a good chance of getting pregnant, and yet there are many, many more unknowns.
Well, we're going to talk about a few of those factors. I think it's important we start off with a good working definition of infertility. What is that?
For most people, unprotected intercourse on a regular basis for a year, if this hasn't resulted in pregnancy, we can consider them infertile.
Now, can you modify that on age?
Of course. I think that with the older couple, by older I mean around 40, then we would probably not wait a whole year before considering the possibility of an infertility workup.
Okay. Let's talk about some of the social aspects and psychological aspects of this problem. Very important, isn't it?
It is, and the first part of an infertility study is to really take a careful history from both the husband and his wife, because frequency of intercourse may very well make pregnancy very unlikely. If the husband is on the road a lot or the wife is traveling a lot, it's really only during a relatively brief period of time each month, each cycle, that pregnancy can occur. And if they're not together, that's a cause of infertility.
I guess it's also important to find out why a child is important to this couple, wouldn't you say?
Yes, of course. It's very important that they really do want to have children rather than just establishing that they want to see if they can get pregnant, because there are some people who really just do want to establish whether they can get pregnant rather than actually nurture and raise a child. Whether they want to put in the degree of effort and time that can frequently be involved in working up the infertile couple may sometimes deter people from going any further than just waiting to see if nature will take its course.
This will take time, and it is very stressful at this period of time, isn't it?
It needn't be stressful, but an infertility workup done at its most efficient probably requires at least 4 to 5 months of study. Some of the tests that have to be done can only be done at a particular time during the month, and you can't do them all during the same month. So that even with attempts to streamline the workup, a couple who then decides that they're going to find out why they can't get pregnant, first of all, will probably be advised not to get pregnant because some of the tests might interrupt a pregnancy, and therefore some of the frustration and room for frustration becomes apparent.
Also, too, when you've been waiting for pregnancy, 9 months seems like a long time. However, when you are pregnant, it's in the course of the child's life, 9 months is a very short period of time, and so times get very distorted to us psychologically, these sort of times of stress.
I know in our culture, as in most cultures, having a child is very important, but a lot of couples have made the decision to be voluntarily childless, and they'll also come to you, won't they, to make that, help them make that decision?
That's an interesting other side of the coin when we talk about infertility. This would be a form of voluntary infertility, And I believe a physician has a role in helping a couple that have maturely decided that they don't want to have children and never want to have children to achieve some safe method of either contraception or sterilization, if that's more appropriate for this particular couple.
I guess one of the first things you might evaluate, in addition to this history, is whether or not an egg is being passed from the ovary. How do you go about that?
Most of our methods of detecting whether an egg has been released from the ovary are indirect. The only way we have of directly finding out whether somebody is ovulating is either by looking at the ovary at the time of ovulation or by somehow collecting one from the uterus on its way out of the body or to fertilization. But we do have some indirect tests of ovulation. The first one is the temperature. The ovary after ovulation produces a second hormone, and one of the side effects of this hormone is to slightly raise the woman's temperature. It's not fever, it's slightly raise the temperature.
I'm glad you said that.
And so on a routine basis every morning, if somebody records their temperature, then we're going to be able to see on a cyclical basis as to whether ovulation has occurred. Also too, with we can take a tiny little sample of the lining of the uterus that can show us the effect of whether ovulation has occurred.
Sort of like a scraping, a DNC, and you'd say...
Not quite as extensive as a DNC, but just a sort of mini DNC.
Okay. Lou, what is this interval as far as ovulation? What is the time frame that pregnancy could occur? How long a period as this egg traverses the tube and the uterus?
If we assume that this woman is a regular 28-day, has a regular 28-day cycle, then
by which you mean from first day of her period to first day of the next period.
That's correct.
Good. All right.
Then we would assume that on day 14 of that cycle, 2 weeks before her next expected period, ovulation would occur. And it's during a very brief period of time, 48 to 72 hours, that that egg is able to be fertilized, and therefore intercourse has to occur within that 48 to 72-hour period that particular month. Otherwise, fertilization doesn't take place. We do have a diagram to show here exactly where fertilization does take place within the fallopian tube.
Okay, so fertilization occurs in the fallopian tube, and then where does the egg usually go on this diagram?
Actually, the egg continues to go through the tube, and then ultimately on about the 23rd day of the menstrual cycle, that is about 9 days or 5 days before the next period is expected, the egg will actually embed itself into the lining of the uterus, and that's called implantation.
Okay, so I guess the next area of concern is how good this fallopian tube is to carry this egg along.
That's right, and one of the problems with as physicians that we have on diagnosing the infertile couple is that our tests are much cruder than the process involved. We can test whether a woman's tubes are open or not, but we know that just the fact that they're open is not sufficient always for pregnancy. But we can use either an X-ray or a dye test to see whether the tubes actually are open or not.
Why is there such a concern about the tubes these days? Has that changed? Has that become more of an important problem?
It's been a pretty well accepted observation that the frequency of infection, genital infection, venereal disease involving the fallopian tube has increased. And potentially, once the fallopian tube has been infected and heals improperly, it may really be either functionally or actually occluded and not allow either the sperm to reach the egg or the egg to reach the uterus.
Some other concerns, and I know you do take a good history, thyroid problem sometimes comes into it.
Well, there are lots of systemic diseases, but just general ill health forms of things that can, in a woman, that will inhibit pregnancy. Thyroid disease, either too much thyroid or too little thyroid, can be a factor. Some things like some very bad heart conditions and things will interfere not only just from the disease process itself, but also from coital frequency and from the couple's relationship too, which will have factors influencing the
How about the
fertility.
way a woman's psychological reaction about eating or not eating? Does that ever affect her potential as far as fertility?
Yes. Women who are anorectic, who don't eat enough, their periods stop, and when their periods stop, their periods stop because their ovaries are not functioning correctly, and so they are not going to get pregnant until regular ovulatory function resumes.
A lot of women are doing regular exercise, and many women would be considered athletes. And how does that affect fertility, Lou?
There's a threshold. The regular exercise usually is not a factor in affecting fertility. I think it's the extremes of exercise, and many of the athletic women, the runners, the long-distance swimmers, the marathon runners, in particular, may condition themselves down to the point where they virtually are free of body fat. And when they reach a critical weight, their ovaries really stop functioning. They almost revert to an adolescent type of functional state, and without ovulation, there's no periods and there's no pregnancy.
What does the fat have to do with their ovaries working?
It's not the fat itself that influences ovarian function. It's just a sign that they've gotten down to a critical body mass, which is a loss of fat, which does have a direct effect through the central nervous system on ovarian function.
I have a patient who, when she runs 5 miles a day, does not get pregnant, and when she does want to get pregnant, she just cuts her running down to 2.5 miles a day.
Oh, that's delightful.
That's novel.
That's delightful. Okay, we've talked about taking the temperature. You might want to, how do you set this up with your patient in the office?
You don't have to, but it really is much easier to buy a basal body temperature thermometer because, as I said previously, it's not fever, and so you're looking for small differentials of temperature grade. And what we do is we have the woman take her temperature every morning before she gets out of bed, before she's had a cup of coffee and before she's chased the children out of the bathroom and things, and record it on a regular basis, and we can see from this the changes, a reflection of the hormonal changes in her body.
A woman doesn't ovulate every month, right?
No. Most women ovulate most months, but there are a great many times that ovulation does not occur and does not mean that anything is wrong.
Okay. There's another partner involved. What do you do to evaluate the male partner?
Very early in the course of an infertility workup, it's extremely important to let the male partner know that there's a 50-50 chance that he is responsible for the lack of fertility. Very often there are multiple factors, with both partners contributing to the infertility. But at least in 50% of infertile couples, the basis is a low sperm count or sperm that are non-functioning in the male.
So you actually, under the microscope, look at the sperm and
Yes.
do an evaluation.
Age has a factor with men as well. It's fertility in men does drop off with age, the same as it does with women. There are other factors too in lifestyle with men. For example, there are some construction workers who work out of doors in the Southwest who find that their wives have considerable trouble getting pregnant until they learn during the summer months, just because of heat.
The heat in the scrotal area affects
Yes.
the amount of sperm production.
That's right.
Oh, that's really interesting. Another factor, Lou, is the mucus evaluation. Tell us a little bit about that.
The cervix, which I can show you here in this diagram, does produce a substantial amount of secretions which is recognizable as mucus. Just about the time ovulation occurs, the mucus changes dramatically, both in its amount and its appearance. It becomes so easily stretched out that it sometimes will be stretched over 6 or 8 or 10 inches in length without breaking up. It's very, very clear, and if you look at it under the microscope, it really contains very few cells.
Looks like egg white, doesn't it?
Very much like egg white, and actually at that point, it's best constituted to provide a good environment for the sperm, which are deposited here in the vagina rather than in the cervix directly.
So this mucus does serve a function for fertility. What function does it serve?
As to allow the sperm easy access to their path up through the uterus to the tube.
Okay. What would be your next step as far as the evaluation in regard to any the uterus?
Uterine factors are not as nearly as common method of part of problem with infertility. However, sometimes when we do the endometrial biopsy looking for the indirect evidence of ovulation, we will see evidence of chronic infection or chronic thinness of the lining of the uterus, and those can be factors that can be remedied quite easily.
I think it's important also in some cases to consider the possibility that at some previous time this woman may have had an intrauterine device inserted in the uterus, about which she's completely forgotten.
That's right.
And so very often a very obvious cause of infertility is one that she should have known about but forgot.
Can an intrauterine device damage or lessen the chance of a woman subsequently becoming pregnant after it's removed? Anthea, is that a problem?
Intrauterine devices can facilitate infections in the tubes and the ovaries. They do not cause the infection themselves, but they cut down the resistance of the uterus and the tubes and the ovaries to infection. And therefore we do see more tubal and uterine infections associated with intrauterine devices than we do without them.
Okay, we've established our chart. We think we know when the fertile times might be. What do you say to this couple next? What's the plan?
Well, as part of an infertility workup, most physicians, before they'll make a definite diagnosis, will do a procedure called laparoscopy. Laparoscopy has several useful features in diagnosing infertility. First of all, it's done under general anesthesia. It's done in a hospital or ambulatory care center. It basically consists of using a telescope to completely examine the tubes, ovaries, and uterus from the inside. The types of things that might appear on laparoscopy, which would be unsuspected by other tests, are endometriosis, a fairly common disease which may be associated with infertility and may actually be causative. Very often this will come as a surprise on a laparoscopic exam. The patient has no symptoms and the examination was not suggestive of all of endometriosis, and it's only when you're doing this test as part of an infertility workup that endometriosis will be detected. We'll take the opportunity at that time to inject some dye through the cervix and actually see the dye go through the fallopian tubes and spill into the peritoneal cavity, and that's another means of assessing tubal patency without using x-rays. Laparoscopy has become a very useful procedure, and I think probably is included in most infertility workups now.
I agree.
And it's a well-tolerated procedure too, yes?
You feel like your stomach's been kicked by a mule afterwards, but the long-term effects are very few and short-term duration.
That's good. Okay, we've established that everything looks positive as far as the ability to become pregnant. What's the next approach to the patient?
If we've worked out that basically an egg is being produced most months and that the tube is open and functioning correctly and that the lining of the uterus is reasonably healthy and that cervical mucus is fertile, I think and that the sperm count is adequate and that the sperm are going through the cervical mucus at the fertile period of time adequately, I think then we have to sit down and hold a serious discussion with our patients in the office on a routine gynecological basis as to whether and in what way we're going to proceed from this point on, don't you, Lou?
Yes, I think that's a very critical point in the workup, because basically they have several options which they have to make the decision about. It can't be made for them. One, many couples will decide that they really are made very anxious and upset by the whole investigative effort, and they really don't want to pursue it any further, and they may need some time off without any workup.
They need to really digest this. This has been kind of overwhelming.
Well, just to forget about it for a bit and to remember that there are other aspects to the sexual relationship in a marriage, not just procreation.
Okay.
A smaller number at that point may really not be satisfied that all stones have been left unturned, and they really will suggest, or it will be suggested by us, that they see a specialist in infertility who has a few more diagnostic procedures and a few more insights to offer such a couple. The success rate of the super specialist really falls off a lot. I think it's important to mention that a good number of our infertility patients will conceive either right after the first visit before the workup is scheduled or sometime right after the workup within the first few months. There are some magical components.
Well, and also, too, there are some wonderful things that we can do. The woman who is not ovulating can be very simply treated in the office.
You can bring on ovulation.
We can bring on ovulation very frequently by very simple and very safe methods of medication. Just a healthy discussion on the role of anatomy and physiology in conception can frequently turn the course of events around dramatically.
You're implying that many couples never have really gotten the proper sex education as far as procreation that they should have. Is that right?
Completely true. It's the vast... I would say the majority of patients can learn something from an interview in the office with a physician about reproductive physiology. Wouldn't you, Lou?
Yes, I think that's important. And we've all seen patients who have been married 20 years, who may or may not have had an infertility workup, and who have not changed their sexual habits at all, and suddenly will become pregnant. And that's as mysterious as why people can't become pregnant.
I guess it's very common with many women with their own careers and other reasons to delay pregnancy, and they may have been specifically on the birth control pill. Sometimes there may be some startup problems afterwards. Could you talk a little bit about that, Lou?
Fortunately, most women who were ovulating before they started the birth control pill will resume ovulation within a reasonable period of time, but they fall into the category, if they don't ovulate, of patients who are fairly easily treated by one or two methods to produce ovulation. That's not a major problem.
I don't really think that the pill causes infertility, do you, Lou?
No.
The pill can be blamed for many things in our culture, but not really as a cause of infertility.
The older woman, and I use that advisedly, who's never been pregnant and now wants to get pregnant. There are some considerations and some problems, aren't there?
We have to be a little cautious as to what we describe as the older woman. There used to be an old saying that over 32 having your first baby, you were called an elderly prima gravida. Remember that?
That definition's changed.
That was a rather unkind thing. I don't think that either Lou or I would consider somebody particularly old at 32 having their first baby now. There are considerations for the over 40-year-old woman starting a family. Most of those, though, I really feel are much more from the baby's point of view than the mother's.
Lou, what kinds of things can you offer such a woman who might be concerned about a baby at the age of 40?
I think most people do know that really at age 35, the risk of having a baby with a chromosomal abnormality tends to increase and really becomes fairly substantial at age 45, and in between the rate goes up. So that there is a risk of Down syndrome, of extra chromosomes that can really seriously impair the baby's health or threaten the baby's life. Fortunately, the chromosomal abnormalities can be diagnosed prenatally by genetic amniocentesis. A test done at 16 weeks where amniotic fluid is removed, the cells in the fluid are cultured, and the baby's chromosomes can be checked for normalcy.
And this can be very reassuring also, isn't it?
Most often it is.
Mm-hmm.
Okay. Now, occasionally there may be some unusual causes of infertility. For instance, maybe the pituitary is not working right. Rare, but does happen, doesn't it?
That's right. Particularly with the pituitary can get a condition a little like a hyperactive thyroid, and this will make somebody's periods slack off and become very scant or absent, and frequently associated with milk production from the breast, and that can be treated with medication.
I guess ultimately there may be a group of couples that may have to accept their childlessness. You work with some of those people too, don't you?
They're not a frequent part of a practice, but they really often do require counseling, because if nothing else, they need some reinforcement of their own feelings that maybe childlessness isn't all that bad for them. We're in a totally different time in history when children really are no longer necessary to provide a labor force, and we haven't quite worked out exactly all those things that children are required for, but I think it's legitimate to say that some couples probably would be much more comfortable and live happier, more productive lives childless.
Or they could adopt a child, or
Exactly.
be a foster parent.
Or be a good surrogate parent to other people's children. There are very many good, kind aunties around that fulfill a very, very useful
Yes.
function.
And there's the single woman who wishes to have a pregnancy too. Let's talk about that.
We see patients who are single who want to have children, both men and women. It's rare, I think probably rarer in men than in women. And it's a difficult subject to deal with because it takes two to get pregnant. And so that we do need to work out exactly what we're dealing with. And somebody who comes in who at the age of 25 is really concerned about her fertility. She says that she's been sexually active since 18 on, and she is very concerned about her fertility. I'm not sure that I think that's a fair test of fertility. I think it goes back to what Lou was saying earlier about regular intercourse and availability and exposure to pregnancy. And I think that for most people we need to wait and see what happens in a stable relationship with regular unprotected intercourse.
It's a little difficult to start an elaborate fertility or infertility workup on a young woman in that situation. I guess in some circumstances it may be appropriate. I've been impressed with some young women who have decided not to have husbands but to have children, and who, after much discussion, counseling, have convinced me that although it might be better for a child to have two loving parents, it may not be all that bad for a child to have one very caring parent.
Oh, I agree with you there. I wanted to get back to the super specialist. Unfortunately or fortunately, our media has made a great play on this. This does require quite a bit more elaborate laboratory, and it's a more expensive process. Let's talk a little bit about that, because that's a realistic consideration for a lot of people.
Well, probably the super specialist serves the greatest practical role in the patient whose tubes are damaged or destroyed. Here there have been a lot of advances made in terms of getting the pregnancy to bridge the gap in which the egg is actually retrieved from the ovary, fertilized outside the uterus by the husband's sperm, and re-injected into the uterus, so that the tube virtually is unimportant in this situation. In vitro fertilization is what I'm referring to. And this is a procedure which maybe 1 time in 20 may be successful in producing a pregnancy, and even then this doesn't mean term pregnancy. It means a pregnancy that at least is conceived in the uterus but may miscarry. It's a very expensive, very involved procedure, and it's really only suitable for patients that don't have functioning fallopian tubes.
And that may be because of the infection or ectopic pregnancy or damage?
Or endometriosis.
Or patients who at one point in their life decided they didn't want to have any more children, or didn't want to have any children, who had their tubes destroyed by, as part of a sterilization technique. We see that fairly frequently, in which the tube just can't be put back together again.
Let's talk a little bit about that, Anthea. A woman does come to your office and said, I had a part of my tube cut or tied. Can you hook them back up together? Let's go through that a little bit.
First thing we need to find out is what sort of procedure was done, and so that we try and get the records and establish what sort of procedure. Then the second thing we usually do is do a laparoscopy to find out exactly, looking at the tubes, whether there is any residual tube and what exactly we're dealing with. And then there are people who are surgically very skilled at putting tubes back together. I do feel, though, that tubal reconstruction surgery is a super specialist job.
I agree.
That's not the work of an average gynecologist. The best success rate is people who do a lot of those surgeries on a very regular basis, and not the average gynecologist who's very competent at doing things that super specialists don't routinely do.
It's really a microsurgery technique then.
That's right.
There's another condition I guess we didn't talk about, and that is where the ovaries might have a very tough surface so that the egg can't escape the tube. Let's talk about that a little bit.
These are the women who don't ovulate very regularly, and we have drugs that we can use. There's one very common drug that we can use that frequently is extremely successful. Beyond that, we get into the super specialist realm, where which is where frequently we can have the multiple births.
So you can help most infertile couples, or at least half of them. Would that be fair to say, Lou?
I think that's a fair statement, and basically it's one that probably is going to improve over the next 10 years because of a lot of the information we're gaining from some of the newer experimental techniques in treating infertility.
I think we can help all of them, because I think discussing the problem and putting their particular aspects of it in good perspective is always beneficial.
Well, that's really the most humane thing, in helping patients live with the situation that they're in. I hope you've enjoyed some of these remarks. I've certainly thought they were interesting myself. This is Dr. Ron Spark saying thank you for joining us for Prescription for Health.
Today, you have watched a program about infertility. Your host was Dr. Ronald P. Spark. His guests, Dr. Anthea Dixon, whose specialty is obstetrics and gynecology, and Dr. Louis Scher, whose specialty also obstetrics and gynecology. The doctors of the Pima County Medical Society want you to be informed. We'd love to hear from you. Please send your comments or questions to the Pima County Medical Society at 5199 East Farness. That's here in Tucson, and the zip is 85712. This is Connie Rye. Thank you for joining us.